afternoon, everyone. Thanks for dialing in. We're here with you at 2 o'clock for the Interoperability webinar here from Wellcentive. I'm Greg Fulton. I'm the Industry and Public Policy Lead here at Wellcentive. I'll be introducing our two main speakers. We'll cover a lot of ground today, rightfully so, on the topic of interoperability. That's certainly a very big topic, and as health IT advances and as payment models advance, and they try to do so concurrently, interoperability is certainly a big part of that, getting a lot of attention, as I'm certainly, you are aware, a lot of attention even at the congressional level. We've got a lot of pending bills still that look at interoperability and look at certification, some carrots and some sticks. You see some of that moving into certification of health IT products. You see some of that moving into payment models, big scale payment models such as macro. Macro, is going to demand scale, it's going to demand volume on the data. For interoperability, you're going to be putting a lot of data through a lot of reporting and getting it off to payers. So a lot of that ground we will cover today. Other questions you're seeing in the industry: can state and regional HIEs be sustainable? That's something that's being looked at now. There's a lot of vendor collaboratives in the industry as well right now. We spoke a little bit about certification, API technology, patient-generated health data. A lot going on in interoperability, rightfully so. So we won't delay much longer, get here right to our speakers. We'll talk about volume, scale, things like that you're going to need from a pop health level to meet some of these value-based payment models and things like that. So let's get our speakers underway, and I'll jump in with some questions later, and we'll be looking for your questions as well. We'll have a lot of time for some interaction today as well. With me today, of course, Mason Beard is our co-founder here at Wellcentive. He's also our Chief Product Officer. Joining him today, Phillip Burgher is our Manager of Director of Data Platforms and Software here at Wellcentive. Really our interoperability lead in some of the collaboratives we're into. Spends a lot of time in Washington, D.C., goes to the ONC annual meetings, spending a lot of time up there with the regulatory and policy initiatives as we try to get those pop health use cases into the advancement of interoperability. So, gentlemen, Mason, Phillip, take it away, and thank you.
Thank you, Greg. Yeah, and we're very happy to be talking about intelligent interoperability here. And as Greg noted, Phillip is our interoperability guru here. So as we go through this content, I'm going to kind of set him up, and he'll give you more of the technical answers. So let me just start off. At Wellcentive, we are incredibly passionate about this subject. And it really, I think, is rooted in our DNA and where we came from. So what I wanted to do is tell you a little bit about our roots, where we came from, and give you a little bit of context to why we're so passionate. We feel like that we have a platform to speak on. So we've been around for 11 years, and we've been driving quality and revenue and helping organizations transform into a different way of doing business. And we're very fortunate in 2005 to see there were different ways to pay physicians on services. And we really felt firmly that we were going to move away from fee-for-service. We were going to move into a value-based care world. And to do that, we have to do a better job than taking just claims data. It's going to take a richer data source, a more complete data source, more trustworthy data source and timely to actually perform these actions and help prove value instead of just a volume-based world where the only proof point you have is just how many things you did in a day. So we've been doing that since 2005, and we're really are doing that for a variety of organizations, from IPOs, from IPA, PHO, IDNs, organizations where the physicians are using a variety of different EMRs, and it really is solving the hard problems when you've got a diverse ecosystem and you're trying to align everybody around a common quality program. And these quality programs are very much in the forefront right now of policy in everybody's mind around alternative payment methods and value-based care. When we started, it was around pay for performance. It was commercial plans, incenting on quality, and then it moved into more of the federal programs. So with that, and I guess I can breeze by our fantastic pictures here. Yeah, I am joined by Phillip Burgher, who is going to kind of tag team in each of these slides with me. So here's what we plan on covering, and I do want everybody to jot down some questions for us because we're going to have 15 minutes, maybe 10, 15 minutes at the end of the presentation. We would love to hear from you and ask us the real hard questions. But here's what we're going to cover today. Basically, let's cover how the market is defining interoperability. And then we're going to take it from a different perspective and add on the Wellcentive view of interoperability, which we have coined intelligent interoperability. I would say purpose-driven. And then how does that even mean? What is that function, and how does that play in the world of value-based care? Because we're talking about a technical definition, but then we're also talking about more of a payment model. So how are you going to bridge that gap? And then we're going to talk about more of the strengths and filling the gaps of actually executing on that vision of intelligent interoperability. And then what are you going to be able to derive from results? If you invest the money, if you invest the operational bandwidth to do this, what are you going to get out of it? So we're going to cover that. And then the last is we might touch on what is your growth strategy? You know, you could basically say, no, I'm really not going to buy into this whole intelligent interoperability, and I'm going to kind of stay the course. What are the risks there, and what are the what's the strategy there for maintaining kind of status quo, or you're going to get aggressive and head in this direction? So with that said, let's talk about a market definition of interoperability. So, you know, when I think about the market definition, I'm thinking about basically an exchange of data. And it's devoid of a purpose. It's devoid of, as Phillip likes to say, some of the use cases. So, you know, our not Wikipedia, but our standard definition here is the ability of different information technology systems and software applications to exchange usable data to the right place at the right time. So what's missing there is context, and that's a lot of our presentation today is exchanging the data for what purpose. And that context is we're going to lay on the table here is value-based care and moving people to proving the value of the healthcare they're delivering versus measuring the quantity of the healthcare they're providing. Phil, any thoughts?
Absolutely. Well said. So I would actually add to that definition as well. Exchangeable, usable data to the right place at the right time without additional burden. A large problem with the traditional definitions of interoperability in the market today is that the onus is on the provider. They're the ones responsible for manually querying an HIE to see if there's an existing record out there. They're the ones manually responsible for pushing a referral with a summary of care document using a direct message. And we all know that doctors are strapped for time as is, and so intelligent interoperability simultaneously increases the amount of health information exchange happening while at the same time freeing up doctors to treat patients.
A great point. Low impact, but it is around the mission of value-based care delivery versus this whole world of HIT we feel like is kind of stuck in this antiquated version of its episodic care. And it's putting, you're right, putting the burden on the provider, and it's the opposite of intelligent interoperability. So, you know, on that note, and not to toot Phillip's horn too much, as Greg said, but Phillip is working with groups like the Sequoia Project and others around what are those use cases and what can we do to be thought leaders around that. And I know you sit on the Commonwealth group as well, and it's basically kind of putting the episodic-driven workflows to one side and making sure that the population health management, value-based care workflows are getting some airtime.
Yeah, absolutely. Yeah, we've had conversations with Jitten and his team about how we can make Commonwealth work for a population health purpose.
There you go. So let's start to give a little bit deeper away from the definition. Let's talk a little bit more technical. And what we're doing is in our frame of reference is we are a solution provider that sits in a health system that is using disparate systems. These are independent physician, affiliated physicians using, let's say, 30 to 40 different EHRs. So when we talk about intelligent interoperability, it's not just the use case, it's what are you doing from a technical perspective. And I'll make it real simple, and then Phillip can add in there. We are taking systems that were implemented without the end in mind and implemented with a lot of variability. So when the EMRs were implemented, they're capturing different code sets and they're creating different templates and organizing data without understanding what the discrete code is that is going to be needed down the road for a measurement. So when we talk about the technical aspect of intelligent interoperability, we literally are meaning taking code sets and normalizing them for a common purpose.
Absolutely. Hit the nail on the head. There is so much data out there to be exchanged and already being exchanged, and really only a subset of it is actionable from a quality perspective. And so when we say purpose-driven, we mean don't boil the ocean. Know what you want to accomplish. And so if you're an ACO, know what data is relevant to those ACO measures. If you're UDS, know which data is relevant to those UDS measures. Population health is a very broad term, so you really need to figure out where your goal is, and that's going to drive your interoperability strategy.
And that's going to help you engage physicians, and we'll talk about that in a little bit, but I always use the term, we don't care about hair color. Because that data element may be in your ecosystem, but it sure is not an NQF measure that you're going to use for your ACO.
Right.
So to your point, yeah, let's not boil the ocean from a technical perspective, and let's focus on that value in getting the physicians engaged. So here's what we're doing. So on the screen here is we have what we call a model for growth and movement into a value-based care realm. And it's basically when we talk about leveraging intelligent interoperability, we want to move health systems from the left to the right. And the left is a completely fee-for-service focused organization, volume-driven, into an organization that is starting to get a benchmark of their outcomes, the value they're delivering. And once you do that, you can move into enacting care management and actionable workflows to actually, as I say, fix the numerator. So when you're moving from left to right, the first thing is let's aggregate the data in an intelligent way. Let's get our true north. And then we can start to put in action and workflow to say, wait, if I've got 2,700 patients with, let's say, uncontrolled diabetes, it's HbA1c, how do I fix that? What are the people? What are the actions? What are the physician engagement techniques? What are the care management techniques? Then you're moving more up this maturity model, and then you're in a place where you can take on different alternative payment models. Now, when Greg started this, the webinar, he was talking about CPC Plus and CCM and the ACO and MIPS. There's different vehicles that the government is producing as well as commercial plans are producing that allow you to prove that value. And the farther you are on the right on this scale, the better position you're going to be to prove that value, participate in there, and you're going to have a mix of your revenue. You know, your fee-for-service might be going down, but your value-based payments are going to be going up. And none of that movement will happen. You will be stuck in the left if you don't leverage the data in an intelligent way.
Absolutely. I think of intelligent interoperability as the foundation for this maturity curve. And as your foundation gets stronger and stronger, as you learn to manage your data in more efficient and better ways, you can put more on that foundation and be confident that you're going to be successful in whatever endeavor you're engaging in. And it is important to note that intelligent interoperability, that foundation, isn't just about getting data from point A to point B in an automated fashion. It's really a data management and data governance strategy. And so that is why it's foundational to everything value-based care.
And that data governance is huge because one of the key components to moving from left to right is getting the physicians bought into it. Mm-hmm. They have to have confidence in the data and remember where they're coming from. There's a lot of baggage out there. Number one, they feel like the commercial plans have used claims data against them for years. They don't trust the data, it's incomplete, poorly attributed, we can go on and on. But there's some baggage there that we need to recognize. And our goal, leveraging intelligent interoperability, is to get their confidence level up so they can trust the data and start to evoke some of these workflows. The second piece is they are hurting in this model. They were in a fee-for-service model where it was volume-driven, and then we forced EMRs on them, and that cut into their production. So you are offering a lifeline by leveraging this data and moving, again, to the left or right, but they have to have confidence in it because they're just not in a good mental state right now. And you know, we deal with this every day, getting physicians engaged in this change.
Yeah, and just to kind of draw an example of how we define interoperability is a little bit different than how the industry is defining interoperability. I believe it was last year, maybe earlier this year, ONC put out an RFP for how to define and quantify the amount of interoperability that is happening in the country right now. And a lot of the metrics that were suggested were simply volume, which, again, it's exchange for exchange's sake. Just because a doctor sent 10,000 direct trust messages doesn't necessarily mean they're doing a better job taking care of their patients.
Yeah, Philip and Mason, if you don't mind if I jump in on that point, yeah, they really talked about, you know, how do you measure interoperability? One way they wanted to look at that was through physician surveys. Another way they wanted to look at that was through meaningful use numbers. Meaningful use, as you know, is attacked by Congress for its lack of interoperability. Congress in turn pushed ONC to come out with that RFP to give them some sort of a foundational baseline going into the macro program. You know, and without just going on and on, you know, with this message style here, those we again see as a little bit lacking, you know, in what interoperability really should be or truly should be. But that's sort of the mindset that we're to some degree working against in some quarters and working with in other quarters here in the industry. Thanks, guys.
You can tell we're a little passionate about this. So I'm going to shift gears a little bit and talk about big picture operational workflow. And then we're going to dive really deep into the technical aspect and kind of the conceptual aspect of what the data and normalization is. But from a very high picture here, or a high level picture, is once you interpret the data, then you can get your physicians aligned. Then you can start to scale care management and other workflows to prove that value at the end. So you're transforming, you're moving from left to right, you're transforming the way you are doing business, starting from the data and leveraging it, and ending with a proof of value. And we're going to dive into that, what that really means. But that's it. The old proof statement was a volume of 837s. It was the billing data. The proof step now is, are you delivering high quality, low cost care? And that's the game. So with that, let's take this concept and let's go really deep. So intelligent interoperability, we feel like it's analogous to the UN interpreter. So a proper positioning and a successful function set is one that can sit in between your ecosystem on the left. So you think about how you're organized. You have different physicians and different arrangements. They're using ECW and Epic and Cerner and EMD and on and on and on. And that interpreter has to be able to take that information from the left, normalize it, put it in a common language, and then communicate the value to the right, where that's the purchasers of healthcare. So when we talk about intelligent interoperability, it's purpose-driven, and it's a two-way interpretation. It's a two-way function here, where you're taking that data, normalizing it, and then translating that value. So I'm going to dig a little bit deeper into what we really mean and how complicated that job is. Because I show you a picture of a UN interpreter, you're like, yeah, that I get it. That's easy, right? I mean, they sit in the middle and they get the data on the left and they translate it, and then they send it out to the payers, and boom, here's a value-based care check.
I want to do that.
Right, exactly. It's just easy. But let's get into the let's get into the weeds. So
I like the weeds.
Yes, that's why you're here. When we talk about taking that data and interpreting it, I took one measure. Now, you might be familiar with, everybody knows chronic disease management and kind of the high-risk patients that are costing the most. So I'm going to pick on the diabetes measure here and hemoglobin A1C. But it's very easy to say your NQF measure that is, show me all my patients, that have an uncontrolled hemoglobin A1C. But the slide I'm showing you here is how you break that down from a code set level. So the measurement is this complicated. Imagine if you're taking 40 different EHRs who are tracking the data elements needed to feed this measure and then translate it to a payer. So it is a daunting task. Before I move on, any comments about this one?
Oh, I firmly believe that this is the secret problem that the health industry is facing right now that nobody is really addressing. And this is fundamental to the concept of intelligent interoperability. Just again, taking this measure as an example, you see how PQRS is defined diabetic. You see how PQRS has defined an encounter. For other measures, they have definitions of HbA1c. And you can see that there are some coding systems on there. This is an older measure, so we're looking at ICD-9 as opposed to ICD-10. What happens if your EMR is sending you SNOMED codes, which, by the way, is the recommended coding system that ONC supports in their standards advisory? So all of a sudden, you can see that this is where the rubber meets the road for that translation, and without it, you're going nowhere.
So you hit on a really important point, is that the measure author is different, because those are the academic centers that say, I'm going to define diabetic care this way. They're the NCQA, they're NQF, they're the people that author, American Diabetes Association, that are compiling the great way that you measure something, and it's a little bit of a disconnect with the people that are saying we need to standardize the HIT systems to capture the data.
Mm-hmm.
So herein lies the problem.
Mm-hmm.
The measure authors have all the good intent. The people making the standards have great intentions, but there is an interpretation needed in the center to make use of this data, because no fault of the people implementing the EMRs 10 years ago, but health systems have been in the stage of implementation without the end in sight. They didn't know that this measure here on the screen was where they needed to get to, because they're going to belong to an ACO one day and that's going to have an NQF measure around diabetes.
Yeah, and to tie it back around to, intelligent interoperability, ONC's definition of interoperability includes having data at the right place at the right time that is actionable. And without that translation, without that key part of intelligent interoperability, your data is not actionable.
There you go. So the good news is that, our view of life is we should never show a customer or somebody that's actually providing healthcare this screen. Somebody should be taking care of this for you in the background.
Absolutely.
So let's dig into that a little bit now that we've sufficiently scared everybody. So let's take aggregation. And this is a real world scenario. And I want to take an example. I said our typical client has 20 to 40 different EHRs across their physician makeup. And really what that is if you have a large number of affiliated doctors versus employed doctors, you have a looser span of control over them. Therefore, they're going to maintain and keep their EMR that they kind of have been with for a long time. And it's really hard, if not impossible, to take all of your ECW data and move it to Epic, or all your Epic data and move it to Cerner. So it's hard to move them off of their old EMR, because guess what? Cerner's not too keen on giving Epic their data, and ECW is not too keen on giving it to Cerner, right? Herein lies the problem. So there's an aggregation step that needs to happen here, and I took a real example of Quest, which is a cloud-based lab system that many of our customers use, Cerner, which everybody on this call should be familiar with, is an EMR and mega suite vendor.
I've heard of them.
All right, ECW, and Epic. So
another small shop.
A small shop, yeah. So these source systems, and I did a little homework before this webinar, we have over 1,200 codes for one concept called HbA1c.
Mm-hmm.
Now, for diabetic care and your chronic disease management, kind of low-hanging fruit is going to be those diabetic patients with uncontrolled hemoglobin A1c. And today, over our 6 million mappings, we have 1,200 codes for HbA1c. And these are actually the codes that I found that were listed for some of these vendors. To give you an example, so for the layman, for the common person, 859-88290 doesn't mean much to me. Nor does the GENEP 897, which was the Epic code for HbA1c. So someone has to apply some intelligence to map this concept into something that is going to make sense, it's measurable, and here's the other, don't miss this, that your physicians understand.
And this is absolutely what we mean by purpose-driven. 1,200 codes just for HbA1c, so you can imagine the volume of data that you're getting for hair color. And so you have to get laser focused through your business goals into looking at your data. Otherwise, you'll be stuck in analysis paralysis forever. And that's really not something, that's not a conversation that we're really seeing at the national level. It's just shuffling data from one point to another. Any sort of intelligent analysis of the data. Right.
And not to pick on our HIE friends out there, but that really was the core fault or Achilles heel of HIEs in the past. It was, we are going to exchange data because we need to exchange data.
Right.
Versus the purpose.
Right.
So let's continue on with the story, but basically this is a real-world example of the different codes coming from a cloud-based lab system as well as an inpatient system and an ambulatory care center using different EHRs. So we're going to take that information that is now one concept of HbA1c and we're going to do something with it. So now you can see the context of, now I can find my patients that have an uncontrolled, so now you have a value set that says, okay, I've got all these data inputs for HbA1c, we've normalized these codes, now I can actually leverage analytics, do a query, and say all the patients I have, and this was in the measure, I haven't really talked about it, but 18 to 75 that, you know, could be Medicare patients, it could be Blue Cross patients, et cetera, but basically it's find all the patients that need help. Find all the patients that I need to go and focus on so that I can show the purchaser of healthcare that I'm doing a good job with these high-cost chronic illness patients. So this is the HbA1c, and go find your patients across your entire list of patients. And now let's go engage them.
And this is a great example of a pop health use case that is absolutely dependent upon that foundation that intelligent interoperability builds. Without it, you wouldn't be able to do that normalization. You wouldn't be able to do that you wouldn't be able to have that longitudinal chart. It really is the necessary first step to transforming how healthcare is done.
And for some of you out there, you might be thinking, well, wow, this is great, but who's going to pay for this, right? There's got to be some infrastructure here so that we can leverage the data, and we're going to get into that. We're going to talk about that maturity model and leveraging these programs to pay for this, because at the end of the day, this is where you want to get to. All of those codes that are normalized in an intelligent fashion, it's going to get you to a point where you can focus on Bill and Sam and Kelly and Liz, and once you make an impact into those lives, you prove that to a payer. You're going to prove that, maybe it's through the MIPS program, right, which used to be PQRS. Maybe it's through your ACO, which could be a commercial ACO, or it could be MSSP. But you're going to go from a code set to a person, and that's what you got to focus on. So, but there is a way to fund this transformation. We're going to cover that here in a second.
And just as a side note, again, because I'm the data geek, so I notice these kind of things.
That's why we brought you here.
All of those codes you mentioned in your previous slide were custom codes. Those were not standard. So about half the data that we see out there is custom data. So that means that it's up to you to provide the meaning and the context and the value of that data. And that is all inherent to the intelligent interoperability process.
That's a great point. That's, again, why we don't focus on hair color, is that because of the variability, because of the custom code sets, you really need to get laser focused on what program, what measure set, and data points, and then you rinse, wash, and repeat. Maybe we'll get to a point where, we've reached the end of the internet, all of our data is clean, and now we want to focus on hair color.
I've watched everything on Netflix.
Exactly. But we're going to be very practical with our approach when we're talking about leveraging this data. So here's the practical approach that I want to get to you, or kind of convey here, is that we don't boil the ocean. We're taking a pragmatic approach to leveraging your data, and we're getting just the data points that map to the measure, that map to your first program. You prove success, you get your physicians engaged, and again, you rinse, you wash, and you repeat, and you start your second program. You're going to prove that you can move the needle on quality and cost on one of these alternate payment methods. And there's a variety of commercial programs out there, a variety of federal programs out there. I've used some examples here in the slide. DSRIP is a federal program for Medicaid populations that's administered by the state, and it's basically a way that you can say, hey, I'm gonna affect this population, and we're gonna measure it with these 5 NQF measures, and we're gonna focus on, from an implementation standpoint, the data that drives those measures, so I can show some success. Once that's done, now I have an ACO. Maybe I'm starting with an MSSP ACO, and those measures, so the data set is going to expand, and then you have commercial variants of an ACO that you can participate in. You get the idea. You're aligning your physician behavior, your care management behavior around a common purpose that is driven from the data that is helping prove through the lens of a measure, NQF, NCQA, PQRS, MIPS, etc. But it's very program-centric, and this is how you start small and you move up. I still don't think once you're in your 4th and 5th program you're going to hit hair color, but regardless of that, you're leveraging a bigger data set to impact these programs, and you may get to the point where you're on the fringes. I mean, Phillip, I've had a lot of conversations about leveraging socioeconomic data.
Yep.
That's really getting in there when you're trying to affect a population. Some of those non-standard clinical concepts around transportation needs, or do they have any family help, very, very much kind of on the fringes, but can help you prove that value.
Yeah.
So this is how you start slow, start small, and move up and get your physicians aligned with their program. And, as Greg led off, this is how you fund this transformation. You want to leverage the data, you're going to have to put in place some infrastructure. This is how you fund it. Commercial plans and the federal government have put in place funding mechanisms if you can actually prove that you're doing it. So I do want to touch on 2 other concepts here before we move on. But the other thing that you're going to do is you're going to do things at scale. Once you leverage the data in an intelligent way, now you can start to think like a payer. They've centralized operationally some care management resources, and they are starting to manage cost and quality at a central location, but you're scaling those activities. Once you find, my graphic, the Kelly and the Bill and the Sam, you want to make sure that you're staffing appropriately and growing your staff that are actually doing that outreach and getting the patients back in to make their appointments, et cetera.
And as a note on scale, this really ties back into the whole provider burden concept. A manual exchange of data is not scalable. There's no way that the providers in this country will be able to achieve the level of interoperability necessary to make all of this value-based care a reality with button clicks.
Amen.
And that's why,
yep.
We stress flexibility, we stress automation, we stress scale as part of intelligent interoperability.
And that's a really great point. And the other thing you have heard us say that I want to kind of highlight here is we're not saying put more on a doctor.
No, quite the opposite.
We're saying scale and empower the physician extenders in the world. That might be family members. That may be the patient. That might be case managers, care managers, blended resource from the payer and the health system. We encounter physicians, again, that are frustrated. They are kind of reeling from activity impact.
Mm-hmm.
and they're looking for help. And so when we talk about scale and these care managers, we're really, exactly, it's those physician extenders and not putting on more on the doc. And that's where Phillip has been instrumental in some of those use cases of don't give the doctor another use case to go do this work. Let's scale the organization where a physician extender can help do the work.
Absolutely, and it's incumbent upon the standards organizations, the policy makers, the vendors ourselves to do what we can to save the providers,
right?
Essentially.
Well, I mean, you laugh at save the providers. I mean, look how many physicians are not going in internal medicine,
right?
Family practice.
Absolutely.
Look at the number of providers out there that are retiring early. They're throwing their hands up and saying, I can't deal with this value-based care mess. And the other is you look at the independent physicians. I've said respectfully, this is like the newest refugee crisis. I mean, they are seeking shelter.
Yeah.
And they can't continue hanging up their own shingle. They need to go, and that's why you're seeing a resurgence of IPAs now. So
I would also note too that you're going to start seeing this bleed over into specialty medicine also, and specialists. A lot of the Medicare programs maybe didn't hit pediatrics, for example, things like that early on in meaningful use, but you're seeing your state Medicaid CHIP programs are looking at that now. Bundled payments will sort of move over into specialties as well. You're seeing that too. So specialists will not be immune, in some of this movement over to value-based care and these sort of risk models.
Fantastic point. Family care, internal medicine had been basically the tip of the spear, and with bundled payments, that is the specialists are now being brought into this.
All the ortho demo, and now you're seeing some pediatrics getting some looks as well.
That's it. So let's finish this kind of operational focus on intelligent operability, and instead of the purpose and the mission being I'm showing you how much volume I did, now you're aiming all of your measures, leveraging all of the data to make sure that you're giving the purchaser of healthcare this view. And these dots represent where your physicians, your providers are today, the quality of your services, the cost of your services, and this is where we need them to be. Our goal is to get everybody into the top right, highest quality and low cost. And if you don't prove that, you're not going to be a provider or a health system that is going to win the market, and you're not going to be the provider or health system that is going to be included in the ACO. Because proving that you're in the top right, everybody thinks they are, right? I mean, every health system and every physician thinks they're in the top right. Oh, I have fantastic care of my diabetic population or hypertension population, et cetera, preventive care measures. But being able to prove it, and this is why we wanted to end the kind of operational focus on this is the right-hand side. It's taking the data in that we were showing as that UN interpreter. You've got to do the right-hand side. You've got to prove that to your commercial plans and to the federal government that you're up here in the top right quadrant. That's the name of the game. And that, if I could just show one visualization of what we're doing here of intelligent operability, and as Phillip said, the purpose, it's right there, top right. That is your purpose. So, not in summation, but let's just highlight this point of kind of what the purpose is and what we're doing. We move you from left to the right. Everybody is moving away from fee-for-service, and they're moving to value-based care, into alternative payment models, and you're doing that by leveraging data in a purposeful way. Don't boil the ocean. You're going to prove, because we've laid out the problem quite clearly, that there's a lot of variability and there need to be a normalization layer there. But you cannot boil the ocean. You need to start small, but your movement organizationally is from left to right in this model down here. You're going to improve your quality. You're going to lower your costs. You're going to have physician buy-in because your reports are more accurate. And then again, kind of the big jump is this last bullet point is once you've got that baseline, you start to prove your quality, then you can start to scale your physician extenders, care management, care coordination.
Exactly. How can you become more efficient if you can't measure where you are?
So all of that was from the opinion chair of Mason, Phillip, and Greg. So let's actually put some meat on those bones and talk to you about some customers out there that we've partnered with that are actually doing this in the wild. It's not just in theory that we're talking to you about intelligent interoperability, but we have example after example after example of customers out there that are living and breathing this and being quite effective. So I'm going to use one of our customers, fantastic partner in Kirkland, Washington, home of Microsoft and Boeing, and they are an IPA that's made up of 950 physicians across 70 specialists. Now, their catchment area has almost 1 million patients, but their catchment area in the physicians, they have 40 separate EHRs across their ecosystem, and their inpatient system, the actual hospitals they have, are all Cerner. So when we talk about variability in the code sets, we talk about that left-hand side where you're having to actually be that UN interpreter. We are the layer for Evergreen so that they can report quality in a consistent manner. Now, from a business perspective, why would they do that? It's easy for Mason and Phillip to say, yeah, you're moving from left to right on that model. They are moving from left to right on that model by going directly to Boeing, working directly with the payers like Kaiser, and they are linking together from a market perspective with other health systems. So they are participating in a variety of pay-for-performance programs on the commercial side. They are going direct in marketing services directly to employers to say, this is the quality of the care. If you buy from us, right, this is more of a consumer angle. If you buy services from us, I'm not going to sell you the old, yeah, we do more volume. It's when you're selling to an employer, they want to know that their diabetic population, their rising risk population, their healthy workers are being cared for, and you're delivering value. And that value is demonstrated through the measures. Measures are fed from the different data sources and leveraging this intelligent interoperability. So just like the maturity model and just like we talked about start with one program and then move up and kind of rinse, wash, and repeat and program after program. We started off with a program around a commercial diabetic population, and then we leveraged their physician extenders, care managers, and now we are up to multiple programs, and I think we've also engaged home health. We'll go ahead and put those under the umbrella of physician extenders, but it is across the continuum of care now because we've been a customer of ours for multiple years now. But yeah, Phillip, let's get in the weeds a little bit technical here for anybody that wants to hear. All right, Evergreen, what are you doing under the covers there from a technical perspective?
Absolutely, and Evergreen is a great example. One of their initiatives that they are partnering with us on is risk stratification. And so that is a great example of keeping your eye on the ball from a purpose perspective. They use the Johns Hopkins risk stratification model, which is driven by a relatively small set of data, predominantly what you're going to see from claims, so procedures, diagnoses, medications. And so when we talk about being laser focused, that's what we mean. Don't worry about anything that is not going to be used by the model, like hair color, because that's a waste of your time. And so all of the integration strategy, all of the data management strategy, all of the data governance, and we've done a disservice to the discussion thus far by not talking about data quality. All of the data quality focus has been oriented around what's needed to get risk stratification to work, because that's what's going to be the most useful tool for Evergreen.
Yeah, that's kind of going. I'm going to go back to our roots. That when we started the company in 2005, we came into an environment and saw a real big business opportunity because physicians were frustrated with the data quality that the payers were of the reports the payers gave them.
Mm-hmm.
And it was, I can go on and on, but attribution.
Mm-hmm.
It was latency, the timing of the data, as well as robustness, and then just flat out errors.
Right.
So yeah, data quality is a big part of the solution. That to be that UN interpreter, you've got to do proactive data quality. in the real world, routers go down. In the real world, an IT professional will update the LOINC codes of your Epic EMR and not tell the people trying to measure quality, right? That's just what happens in the real world, and you got to have that data quality umbrella or service to be in that UN interpreter perspective. And so a little bit more about this, and I'm gonna. We love Cerner. Cerner is a fantastic partner and great at doing what they do. But many people will say, well, hang on, Evergreen was using Cerner. Why don't you just use that? You really, to be that UN interpreter, you have to enable the different vendors to play well together. And I'm going to tell you from a policy perspective, as we participate in Commonwealth and Sequoia, we see in the real world, if Cerner's there, Epic doesn't come. And if Epic's there, Cerner doesn't come. And they don't talk to each other, even if they're going to act like they talk to each other. So, and it really is, it's a business model. Their business model is to become the pop health center of that ecosystem. Well, guess what? When you have Athena in there and ECW wants to be the center of the pop health universe in that ecosystem for Evergreen, and so does Athena. Jonathan Bush has some opinions on being the pop health center of the universe. So you have competing business models that really are stagnating this information flow. So when we talk about being that UN interpreter, it is critical that you have a stance that is non-polarizing.
Absolutely.
We say Switzerland, but really it's that EMR neutral, payer neutral. It's really hard to be a payer and do that because guess what? My population is not all United patients. That's a member view. So, our perspective where we sit as Switzerland, kind of in this interpreter model and played out in Evergreen, is that we can make everybody play together from a mixed payer mix and a disparate EMR ecosystem. So it's a real barrier that you can overcome by being Switzerland, and we certainly leverage it here. So that was Evergreen, and I want to reserve some time for questions as well. I do want to just do a little plug. If you want any other information, please go to our website. We have an interoperability white paper that the smart person in this webinar did. That was Phillip and Greg. I did not do it. It's fantastic, and you can download that for free. We also have something called a cost of an action calculator. It's a tool that basically says, if I maintain the status quo and not participate in value-based care, what's the real cost? Very helpful when you're trying to evaluate making a purchase. We also have, thanks to Greg and some of the authors, a blog that we regularly update on purpose-driven interoperability and intelligent interoperability. And then last but certainly not least, we would love to have a conversation with you. If any of this resonated, we would love to talk to you about how you can leverage your data and move you more toward value-based care in an intelligent way. And then last but not least, we have our emails. We're always open to questions. If there's something that comes up that you didn't think about, we're always open, and we would love to get start dialogue with you.
Thanks, gentlemen. Don't go away. Let's pause for just 30 seconds or so. I'm going to compile questions. We do have a lot of questions already, so I'll compile some together and be able to verbalize them out to Mason and Phillip. So hang in there just for a sec. Thanks for hanging in there. We are back, and I've funneled 3 or 4 questions over to Phillip and Mason, and they can reiterate those and then jump in with answers. So I hope you're still with us to get your question answered. Thanks. Go ahead, guys.
Yeah, so the first question is, okay, this sounds great. What time are we talking about? Because it's, it's not a magic bullet, a silver bullet to do this. I will tell you, and I'll let Phillip get into the technical details, some vendors are easier or more, quote, open than others. And we also, from an EHR perspective and go live times, is we really are practical with what we do here. Is if the majority of your physicians are on Athena, then obviously we're going to start with Athena and start with that question, or that EMR. And then I guess the third more practical way of looking at this is during the early stages of implementation, even when we're talking.
Let me interrupt you. Read that question verbatim, Mason. Let us all hear what the question says overall.
So what's the timeline for adding separate EHRs? For example, if you go live for 10 to 15 data sources, how frequently do you add additional data sources, and how long does it take you to do that?
So you want to take a stab at that?
Sure.
I'd say there's two answers. One, and it's all, again, it all boils back down to what's your purpose. So let's say you do go live with your 10 to 15 data sources, and the purpose of your integration, your value-based care, is an ACO. What you will probably find is that those 10 to 15 data sources don't cover 100% of the physicians in your network. And so that's where the decision to go out and get more data, and when you go out and get more data, is really a data quality question. First, you have to find those gaps.
Yeah, that's a good point.
And so there's really no universal answer. It's really going to be dependent upon the initial state of that data quality.
And low-hanging fruit.
Yep.
What are you trying to achieve?
Right.
Where's the low-hanging fruit that also is high quality?
Right. So, our typical strategy is to phase it out. We'll hit the vast majority of the physicians that are on one EMR in phase 1, then phase 2, until finally we're far enough down that long tail where we feel like we're ready to, do some accurate reporting. Once you feel confident in the data quality as it pertains to your business goal, then really it's those additional programs that Mason was referring to. So let's say you started off as PQRS, and now you're going to, well, you can't do ACO. Let's go to an FQHC measure.
Yeah.
That's a slightly different data set. So now you need to reanalyze what's in your longitudinal charts and figure out where those gaps are. And again, that's going to drive when you add those additional data sources. Now, as far as the actual implementation time, again, that's going to vary by vendor. Some vendors are easier to work with than others. But it really should not take more than a matter of weeks or months. If it goes any further than that, then there's a problem.
Yeah, we shoot for weeks.
Right.
In the implementation, because you leverage 11 years of doing this, and there's
right.
best practices and such.
And I will say, I was a developer in a previous life, so I always hem and haw giving estimates.
I saw you sweating here in the booth.
But this is where, again, I'm like a broken record. Intelligent interoperability means flexibility. So that means no matter who you're working with, no matter what they produce, as long as it's short of an E.E. Cummings poem, you're able to parse it.
Well, let's save Phillip from all this drama. We'll move on to another question. I've got a couple here in front of me also. Yeah, we should probably talk about this one. I saw in the news that you have merged with Philips Healthcare. What will that mean to your scalability, and will you be able to tap into their technology and devices? And as a second part to my question, you talk about pulling that data from disparate sources. Is that through an interface or through an API or cloud-based? So a little bit of two questions in one, I guess. Yeah, go ahead, Mason, because you were instrumental in this Philips merger.
Yeah, and just to be clear, this is not Phillip Burgher Healthcare.
Phillip Burgher.
Right. This is
1L.
Right, Royal Philips. Yeah, we're very excited about that, and that was around the news probably a month ago that we became part of the Philips family. And I've been speaking a lot about that, kind of in the news and certainly with the analysts, the class, Chillmark, IDC, et cetera. And, it's really simple. Philips has a fantastic reputation and a very large footprint in healthcare, in population health, but also in each healthcare setting. And with our union, we allow context and capabilities for normalizing data to help people move to value-based care. So we have a lot more settings that we're pulling data in from, and a lot more breadth. I would say that if you look at from population health management, and you look at this concept, a broad concept of continuous health, we are not only managing chronic disease, but with Philips now, we can really affect your healthy majority, your rising risk, and your chronic illness in a very broad platform, and leveraging a connected world through the cloud. So very exciting stuff going on it's absolutely been in the news, and rightly so. We're very excited about it.
Yeah, I'll reiterate part two of that question, Philip, more so for you. When you're, words to the effect of when you're pulling this data from all these disparate EHRs, is that an interface? Is that an API? You know, how does that work out? And where do you see that going in terms of FHIR APIs, things like that?
Absolutely. Well, traditionally it's been what we define as an interface, kind of a point-to-point solution, as I'm sure everybody on the webinar is aware that the API is the hot term these days, no pun intended, since I am referring to FHIR. And for us, the interoperability strategy is really determined by how can we get the data fastest. So if it's a point-to-point solution, we'll go that route. If it's a simple file extract, we'll go that route. If the vendor in question wants to use an API, great, we'll go that way. It comes back down to flexibility.
Gotcha. Here's another one, Philip, I think is up your alley. If you wouldn't mind, reiterate that question and do it, and I think we'll have time for that, and maybe we'll wrap.
Sure.
But that's a good one.
All right, the question is, what will you advise new startup physician practices to ensure they must focus on from an interoperability and data aggregation and interpretation standpoint at the time they are kicking off their operations?
That's a great question, and I would say you don't. I mean, and I say it facetiously, but physicians don't need to know code sets. They need to know the program, and they need a program that maps to the measure and the purpose of why you're implementing in a certain way. Don't get into the UMLS and LOINC codes and SNOMED CT with them. You need to get into the program. The visual I had where the line went across the health system and you're aligning around a program, it was DSRIP or ACO, that's the level of the conversation that will explain why you're implementing their EMR in a certain way. And really the practical way of doing this, and I love the question, is, hey, if we're starting from scratch, how do we, help streamline this process? And it's basically streamlining is standardizing the way you're building those templates and you're linking to code sets. But for a physician, they don't need to know that. They need to know the program and that uses measures and it's going to use the data in a standardized way.
Right. Now, that might be a different conversation if you're talking about a data analyst or a CIO or somebody who's
totally different. If it's a Phillip of the world,
2 L's.
That's right, 2L Phillip.
Right, yeah. 2L Phillip. Yeah.
In that case, I would say the best success we've seen is to be able to talk to what happens if you don't focus on data and quality first, because we've seen it firsthand. Your quality measures come out and you have all zeros, and you don't know why. And like you said earlier on, Mason, at that point, the ship has sunk. You've lost.